The pill is sitting on your counter right now. You take it every morning without thinking twice. You check the number on that monitor, compare it to the target your doctor gave you, and either feel relief or low-grade dread, depending on what the screen shows. You have been doing this for years, maybe a decade, and you have trusted that the number you are chasing is the right one for your body. But here is what nobody sitting across from you in that examination room has ever taken the time to tell you. That target was not designed for you, not for your age, not for the way your arteries work now, not for the way your body responds to getting out of bed in the morning. And the gap between the number on your prescription and the number your body actually needs may be the reason you feel the way you do every single day. Tired in ways that sleep does not fix, foggy in the afternoons, unsteady when you rise from a chair, slower than you used to be, and quietly wondering whether this is just what aging feels like. It is not. I am Dr. William Carter, and for over 2 decades I have worked exclusively with adults over 60 in cardiovascular medicine and aging. What I see in my clinic week after week is not dramatic. It is quiet, and it is common, and it is heartbreaking in its own small way. Patients who are doing everything right by every standard they were given, who are faithful about their medication, careful about their diet, diligent about their home readings, and still feeling worse than they did 5 years ago. And when I trace that backward, again and again, the thread leads to the same place. A blood pressure target that was never calibrated for their specific physiology, their specific age, their specific risks. This video is going to give you what that 15-minute appointment never could. Stay with me because the way you understand your blood pressure numbers by the end of this conversation is going to be genuinely different from the way you understand them right now. And that difference is going to matter in ways you will feel in your body, not just see on a monitor. Let me start with something that most people have never been told about their own circulatory system. Something that changes everything about how blood pressure numbers should be interpreted after 65. Your arteries when you were young were elastic. They behaved like rubber tubing, stretching slightly with each heartbeat, absorbing the force of blood pushing through them, smoothing out the pressure waves the way shock absorbers smooth out a rough road. That elasticity is not a minor detail. It is the entire foundation of how a healthy cardiovascular system manages pressure. Now think about what happens over 20, 30, 40 years of use. The arterial walls gradually lose that elasticity. The proteins that give them flexibility break down. Microscopic deposits accumulate along those walls. What were once flexible tubes become progressively more rigid, less able to absorb the shock of each heartbeat, less able to smooth the flow. And here is the critical consequence that almost nobody explains clearly. When your heart contracts and pushes blood into stiff arteries, the pressure spike is bigger, sharper, and harder because there is no elastic give to cushion it. Your top number, your systolic pressure, climbs. Meanwhile, between heartbeats, during the resting phase that your bottom number reflects, stiff arteries actually have difficulty maintaining pressure, so that diastolic number may stay flat or drift lower over time. The result is a pattern that is not the exception in adults over 65. It is the rule. The top number rises, the bottom number stays neutral or drops. And treating this pattern the same way you would treat hypertension in a 45-year-old, using the same targets, the same intensity, the same one-size-fits-all benchmarks, is where the real danger begins. In 2015, a major federally funded clinical trial called the SPRINT trial published findings that immediately reshaped blood pressure guidelines across the country. The trial enrolled thousands of adults at elevated cardiovascular risk and divided them into 2 treatment groups. One group was managed to a standard systolic target below 140. The other group was pushed to an intensive target below 120. The headline result was striking. The intensive treatment group had fewer major cardiovascular events, fewer heart attacks, less heart failure. The results were powerful enough that the trial was stopped early, and within months, national cardiology guidelines shifted, pushing the recommended target for most adults to below 130/80. That is the guideline responsible for a massive wave of prescription adjustments that swept through medical offices across this country. And it is the guideline that is quietly harming a significant portion of the seniors it was meant to protect. Here is what the headline did not tell you, and what your doctor likely never had the time or the framework to explain. The intensive treatment group in that trial did not just have fewer heart attacks, they also had dramatically higher rates of serious complications. Acute kidney injury was roughly 50% more common among the intensively treated patients. Dangerous drops in blood sodium and potassium were significantly elevated. Falls requiring emergency medical care were more frequent. Episodes of sudden, dangerous low blood pressure were more common. And when researchers went back and looked specifically at the older, more vulnerable participants in that trial, the people most like the average 72-year-old managing blood pressure in the real world, the balance between benefit and harm looked completely different from what it looked like in younger, healthier participants. Geriatric medicine specialists, nephrologists, neurologists focused on aging populations have been making this argument in the research literature for years. The sprint findings should not be applied uniformly to all older adults. The risk calculation is fundamentally different in this population. The nuance never made it into mainstream clinical practice. What made it into practice was the number. Get below 130. And millions of seniors have been living inside that number ever since, experiencing the complications the data predicted, without anyone ever connecting those symptoms to the medication on their kitchen counter. I want to tell you about a patient I will call Margaret. Margaret was 78 years old, a retired school teacher, sharp, independent, still driving herself to appointments and to the grocery store. She had been managing her blood pressure for nearly a decade without significant problems. When the guidelines shifted, her internist, doing exactly what the guidelines recommended, adjusted her medications to push her systolic below 130. Margaret was a model patient. She took everything as directed and never complained. Over the following several months, her daughter noticed that her mother seemed to be moving more carefully. Margaret mentioned feeling a little off balance in the mornings. She stopped taking her evening walks because the sidewalk felt unreliable in a way she could not quite explain. She told her daughter she thought it was just her age catching up with her. Her doctor, at a routine follow-up, looked at her seated blood pressure reading, saw a systolic of 126, and told her she was doing beautifully. 4 months after that appointment, Margaret fell in her hallway getting up to use the bathroom at 2 in the morning. She did not fracture anything. But she spent 40 minutes on the floor before she could get herself up, and she did not tell anyone about it for 3 days because she was afraid of what it might mean for her independence. When she eventually came to my office and I did a standing blood pressure measurement, sitting first, then again 2 minutes after standing, her systolic dropped 31 points and her diastolic dropped 19 points the moment she changed positions. Her seated readings looked controlled. Her standing readings told a completely different story. When we adjusted her medication to allow her resting systolic to settle closer to 142, the morning unsteadiness resolved within 3 weeks. She went back to her evening walks. She told me that she had assumed that uneasy, white-knuckled feeling every time she stood up was simply what being 78 felt like. It was not age. It was a medication target that had never been individualized for her body, her physiology, or her risks. What Margaret experienced has a clinical name: orthostatic hypotension. It means a significant drop in blood pressure that occurs when a person moves from lying or sitting to standing. In younger adults, the body's automatic pressure correction system responds within a second or two, barely perceptible. In adults over 65, that response is slower and less precise. Blood vessels are less responsive. The autonomic nervous system, which coordinates the rapid tightening of vessels that keeps your blood pressure stable when you change positions, operates with diminished speed and accuracy. Add blood pressure medications to that picture, medications that are doing their job of keeping resting pressure lower, and every compensatory mechanism your body has must work harder to prevent that standing drop from becoming a fall. The consequences are not abstract. Hip fractures in adults over 70 carry a 1-year mortality rate approaching 30%. A medication-induced fall is not a footnote in a side effects pamphlet. For a 74-year-old who lives alone, a fall in a darkened hallway at 2 in the morning can be the beginning of a cascade that ends independent living entirely. And the single most important detail in all of this is that the standard blood pressure measurement taken during a clinical appointment, the reading your doctor uses to evaluate whether your pressure is controlled, is taken seated after 5 full minutes of quiet rest in a temperature-controlled room. That reading captures one narrow slice of your pressure profile. It tells you almost nothing about what your circulation does the moment you stand up to start your day. There is another concept I need you to understand because it sits at the center of this entire conversation, and almost nobody outside of specialized geriatric cardiology ever explains it clearly to patients. It is called the J-curve. When researchers map blood pressure levels against cardiovascular outcomes across large populations, the intuitive expectation is a straight line. Higher pressure equals worse outcomes, so lower pressure should always equal better outcomes. And across the upper range, that relationship holds. But what the data also consistently shows, particularly in older adults, is that when blood pressure is pushed below a certain floor, risk does not keep falling. It begins to rise again. The graph looks exactly like the letter J, falling through the middle range, then quietly climbing back up as pressure drops too low. The most critical and least discussed expression of this J-curve in older adults involves the diastolic number, that bottom figure on your reading. Multiple large population studies have found that diastolic pressures below approximately 60 to 65 millimeters of mercury are associated with significantly increased risk of cardiovascular events, kidney decline, and cognitive impairment in adults over 65. The mechanism matters, and it is not complicated once you understand it. Between your heartbeats, during the resting phase that your diastolic number reflects, is when your coronary arteries, the vessels that supply blood and oxygen to the heart muscle itself, do the majority of their filling and resupplying. If diastolic pressure falls too low, that resupply is compromised. In an older adult whose coronary arteries already carry some degree of narrowing or calcification, which describes the overwhelming majority of people over 65, a diastolic of 57 is not just a number. It may represent a quiet, continuous oxygen shortfall to the heart muscle occurring with every single heartbeat, all day, every day. Research published in major cardiovascular journals has documented this J-curve relationship clearly in elderly hypertensive patients. The evidence exists. It is not hidden. But the clinical conversation about blood pressure management in older adults remains almost entirely focused on getting the systolic number lower, with almost no discussion of how aggressively pushing that top number down affects the bottom number in the process. So what does the evidence actually support as a target after 65? This is the question everything else has been building toward, and I am going to give you a real answer rather than a simplified one. The honest answer is that there is no single number that is right for every person over 65. The appropriate target depends on your functional status, your kidney function, your fall history, your cognitive health, your specific medication combination, and how your pressure actually behaves across different positions and times of day. What the current geriatric cardiology literature does consistently support is this. For adults between 65 and 75 who are in good functional health with no significant frailty, a systolic target in the range of 130 to 140 is generally appropriate, provided the diastolic is not being driven below 65 in the process, and provided orthostatic drops are being actively monitored and not dismissed. For adults over 75, particularly those managing multiple conditions, any degree of frailty, cognitive concerns, or elevated fall risk, a systolic target of 140 to 150 is increasingly supported by geriatric medicine as the individualized appropriate goal. This is not loose medicine or giving up. This is precision medicine applied correctly to the right population. The question is never whether lower pressure is theoretically better in the abstract. The question is whether the specific risks of aggressive treatment in this specific person outweigh the specific benefits. And for every adult over 65 on blood pressure medication, there are two questions that should be part of every single medication review that almost never are. What has your diastolic number been running recently? And what happens to your blood pressure the moment you stand up? Here is what I want you to do before this video ends. If you have a home monitor, pull up your last 3 months of readings and find your diastolic numbers, the bottom figures. If that number has been running consistently below 65, that is not something to note and forget. That is something to bring to your next appointment explicitly, with the question of whether the medication regimen producing that number is appropriate for your age and your risk profile. If you do not have a home monitor, get one. A validated upper arm model, not a wrist device. Take readings twice daily at consistent times for 2 solid weeks. Sit quietly for 5 minutes before each reading. Record every number. That 2-week log is worth more clinically than 10 years of single readings taken at appointments. At your next visit, ask your doctor 2 specific questions directly. Ask what systolic target is being used for you specifically, and why that target was chosen given your age and overall health picture. Then ask whether your medications have ever been evaluated for their effect on your standing blood pressure, not just your seated reading. If you experience any dizziness, lightheadedness, or unsteadiness when rising from a chair or bed, name it explicitly. Use the phrase orthostatic hypotension and ask for a standing blood pressure test, a measurement taken seated and then again within 2 minutes of standing upright. That one simple test, taking less than 5 minutes in any clinical setting, can reveal a medication-driven pressure collapse that a standard appointment reading will never catch, and that may be the source of every symptom you have been quietly living with and attributing to age. Think right now about one person in your life who takes a blood pressure pill every morning. A spouse, a parent, a sibling, someone who has been faithfully chasing a number for years and has never once been told that the research behind that number did not specifically study people their age, did not account for how their arteries have changed, and did not ask what happens to their pressure when they stand up to make coffee. That person needs this conversation. You now have the foundation to start it. The information you have heard in this video is not fringe opinion. It is the current direction of geriatric cardiovascular medicine, backed by research, endorsed by specialists, and consistently underrepresented in the 15-minute appointments where most seniors make their most important health decisions. Share this with someone who needs it. Leave a comment below telling me what your numbers have been running, whether you are going to bring these questions to your next appointment, or whether something in this conversation made you wonder for the first time whether your current treatment is contributing to the way you feel every single day. I read every comment and I respond to as many as I can. Next week, I am covering something that connects directly to everything we discussed today. The specific warning signs in your routine lab work that indicate your blood pressure medications may be affecting your kidney function. Signs that standard panels routinely miss and that most patients are never told to look for. If you are on blood pressure medication, that conversation may be the most important one you have all year.